Welcome back to Mayo Clinic Cardiovascular podcast series, Interviews with the Expert. I'm your host, Sharonne Hayes. I'm a non-invasive cardiologist and vice chair of faculty development and academic advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. And today I'm joined by Dr. Kathryn Larson. Welcome.
Thank you so much for having me, Dr. Hayes.
She's an assistant professor of medicine, an echocardiographer, and co-director of our sports cardiology clinic here at Mayo Clinic in Rochester, Minnesota. And today we'll be talking about cardiovascular care of the masters athlete. Dr. Larson is going to share with us the current research on the influence of exercise on cardiovascular physiology and health. And she'll talk about her research and the effects of lifelong endurance exercise exposures on cardiac function, exercise capacity, and particularly as applies to women and to masters athletes, because this is a really unique population. So, Kathryn, let's start with the basics. How are you defining a masters athlete?
That's a great question because definitions are something I think the study of older athletes certainly struggles with a little bit. But the definition of a master's athlete traditionally is someone who is involved in kind of structured competition or regular training with regard to sports participation and is over the age of 35, which doesn't seem very old to be calling them master's athletes, but nonetheless. And one of the main reasons actually that age of 35 has kind of been picked as one of the defining characteristics is that unfortunately, especially when we look at the more kind of dangerous sides of exercise and cardiovascular health, things like causes of sudden cardiovascular death or sudden cardiac arrest during athletic competition really start to shift around age 35. So whereas in a young population, we might expect to see things like genetic heart rhythm disorders or genetic cardiomyopathies, around age 35 is really where we start to see the inflection point that the rates of death associated with traditional cardiovascular disease in adults, like coronary artery disease, really start to increase. So that age of 35 is there for a pretty good reason. And to be honest with you, I think for most of our athlete population, that's also, especially for the females, kind of a time of life where you're really starting to get ready for other major physiologic changes, whether it's things like menopause, and you're really starting to kind of capture the beginnings of those other transitions in life. So 35 is a traditional cut point. Various studies may use something more or less, and granted, all things in science and medicine are a little bit of a gray and not just a black and white, but that's the traditional definition.
So you have spent a lot of time studying this and continue to look at this population. So what's interesting and unique about these older adults who continue to maintain a high level of exercise training? Perhaps they were college athletes and they just keep going, which most adults do not.
Yeah, no, I just think it's such a fascinating population that we have a lot to learn from, to be honest with you. I really think that for many masters athletes, even those who end up with cardiovascular disease or end up with other disease, they still represent a really important model of healthy aging. And oftentimes, of course, in clinical medicine, we're thinking about disease and disease-specific medications and treatments and therapies. I really find it interesting to look at the other side of the bell curve. What about those folks who are actually able to achieve excellent levels of cardiorespiratory fitness for a long period or even very late into their life? I think they're really a wonderful natural model and a kind of an experiment of nature, so to speak, that we have a lot to learn from. And for better or worse, many of them don't actually even necessarily come into the clinic to see us. So they can be a little bit of an elusive population. But then again, I think we have so much to learn from those people who actually end up doing very well and are highly fit later on in life.
Yeah, I think that's a paradigm, is sometimes those outliers who are very ill, we focus on, on the ill side in medicine, whereas sometimes those people who never show up in our office are the ones we might be able to learn a lesson and apply to the ill population or the at-risk population. So obviously with aging, we have an accumulation of both cardiac and non-cardiac, like arthritis, that impact cardiovascular function. So what can we learn, or what have you learned from these masters athletes, how things like aging and menopause and cardiovascular disease interact with this lifelong habit of exercise?
Yeah, I think the first big takeaway is that there still is a relatively large population of folks who are extremely active, competitive, maintaining a high level of training and a high level of fitness throughout their entire life. So I think, first of all, it's just an awareness that those folks are out there and in increasing numbers, especially if you stop and think about, let's say, the female athlete population. If you were in high school around the early 1970s when Title IX was passed, you're now getting into your Medicare age. And so there's really a lot of young women who actually have had, as never before, a lifetime of exposure to athletics and regular structured exercise. And so I think there's a huge opportunity for us to
Mhm.
learn what that looks like. There's a lot of great studies too that just look at questions about trainability, because we often think of exercise as not only therapeutic, but protective for so many things, both in cardiac health, but also in non-cardiac health. And then there's always questions of, what does the dose response relationship look like? If we're really trainable, do you have to have been a competitive athlete your entire life to accumulate those benefits? Or actually, for many of the patients I see, their kind of competitive exercise career didn't really take off until after their kids were graduated and out of the house, right? Now they've got some free time, or they're nearing retirement, or maybe scaling back on work hours. And they look around and say, well, I want to do something for myself that keeps me healthy and fit, and I'm going to take up triathlons or marathons. And they can really achieve pretty remarkable things, even if they take it up later in life. So I really find those questions of kind of dose response and how might a lifetime of exercise impact what things look like when you're in your 60s, 70s, and 80s, and how much exercise dose is enough, let's say, to take someone who is maybe sedentary or recreationally active and then really start to have an impact on their cardiovascular function, their overall morbidity, and their overall mortality.
Just taking another definitional question, when you say this high level of physical activity, how are we defining it? Is that self-defined, or is there actually, a number of hours or day frequency, intensity? How are you or most defining this?
Yeah, that's a great question. Well, I would say there's a couple of important benchmarks to think about. One is if we think about just what the recommendation is, right? The recommendation is for all of us to get 150 to 300 minutes per week of moderate intensity exercise. So to me, if I'm going to think about the most important definition, that's probably the most important. And then if we look at a kind of dose response curve, if you go, let's say, up closer from 300 minutes, maybe to 500 minutes, or about 1,000 minutes per week of moderate intensity, or a similar kind of, let's say, it's about 75 minutes per week of high intensity exercise, if you're going up closer to 150 minutes per week of higher intensity exercise or higher, there's a pretty long kind of flat portion of that curve where we see that folks tend to be healthy at those levels, but there's not necessarily a huge change in their overall mortality. But I would say for the folks who really exist at the highest end of the bell curve, we're probably talking on the order of about 5 to 9 hours per week, at least, of higher intensity exercise. And there are some interesting studies that look at, how much is enough to start generating things like enlargement of the ventricles or changes in heart rate. But in my mind, that sweet spot, certainly at a bare minimum, is at least 300 minutes a week of moderate intensity exercise, or 150 minutes of more vigorous intensity exercise. And then if you go up from there up to that about kind of 8 to 12 hours per week mark, you really end up capturing a pretty large population, but still a high kind of part of that bell curve where we really can start to see some fascinating changes in physiology. And I'll say too, if you're going to take someone who's pretty sedentary or recreationally active and start to really put them through a training regimen, it probably takes about 2 years of kind of consistent exercise for us to actually see. It doesn't mean that you don't feel better in the meantime or have other changes, but to really start to see major changes in terms of peak fitness, in terms of cardiorespiratory fitness, in terms of heart muscle function, or things like myocardial function or physiology. Those things really start to accumulate more so over the course of probably months to years than over the course of weeks.
But you can lose it really fast, right?
You can
Somebody
definitely lose it
somebody
fast.
slips on the ice running and breaks their leg. Um, uh, right? I mean,
Oh,
it really there's that. That's very interesting as well.
Oh, absolutely. Well, I'll say when you really drill down, if you were to kind of go through the PubMed literature and start to search out some of these really interesting, let's say, small case series or case reports of these folks who are truly incredibly high achievers, the world record holders at the masters athlete level in their 60s, 70s, and even 80s and older. Part of the defining characteristics of their success oftentimes is avoidance of injury. And
Mhm.
so their ability to continue to have those high levels of fitness part of it's due to their training, but also a lot of it is just due to the fact that they managed to avoid career ending or career altering injuries. So yes, I completely agree that kind of time out of training, whether for injury or illness, certainly can have a major impact. And I always even love to reference the good old Dallas bed rest study where they took these young, healthy men,
Mhm.
put them in complete bed rest for a very short period of time. And even just a couple of weeks of bed rest was about 40 years of aging in terms of what it did to their exercise capacity. So, and as a young person, that's recuperable and retrainable. I would say that kind of resiliency probably starts to decline with age, just as your peak VO2 is going to decline with age. So, absolutely, avoidance of injury or illness and being kind of conscientious that the rate of loss can certainly be something that can be hard to crawl back from. Definitely.
Yeah. So, there has been some talk about exercise, increase coronary calcification, all of these things. Is there a thing as too much exercise? I know there can be too much exercise if you start getting plantar fasciitis or something, but how about from a cardiovascular standpoint?
Yeah. Yeah.
That's a key question, right? Because
Oh,
we've been taught like more is better.
yeah. Yeah. Well, I would say for many of my patients who come in, if they are kind of worried about, am I doing too much? Am I hurting myself? Am I harming myself? The basics still ring true, right? Exercise is a therapy. Exercise is an important way to maximize your overall health and fitness, but it's not a panacea. And so I also think we have to be careful not only about, let's say, is exercise going to do things intrinsically to start to impact, let's say, disease risk or overall mortality, but also it can't be an excuse for eating an unhealthy diet. It can't be an excuse for not treating hypertension. It can't be an excuse for not treating hyperlipidemia, just to say, well, I'm fit, so I'm okay. That actually really does start to catch up, especially to those master athletes as they get older. So to me, when I have patients come in and they're, let's say, worried, my partner tells me I'm doing too much, or I'm worried maybe I've done too much and I'm starting to hurt my heart. That's a pretty nuanced discussion that has to take a lot of factors into account. I would say, just at face value, if I had someone come in who really didn't maybe have any true symptoms or concerns, and they're just trying to be conscientious and not put themselves at risk of having something bad happen to them, well, first and foremost, in all honesty, your point about things like injury or plantar fasciitis, the other big one for me is the cyclists who get hit by cars and aren't wearing helmets.
Yeah.
It's just the basics, right? Take care of the basics first. Any exercise is a little bit of a risk exposure for many different variables. So take care of that. And then, second of all, I do educate some patients, especially the older male patients who really are truly exercising at high volumes and maybe have been for many years, about the things like the association with atrial fibrillation. There's really interesting data in older male endurance athletes that they may be at higher lifetime risk of atrial fibrillation, kind of a U-shaped dose response curve. The truly sedentary folks are probably at the highest risk. But for many of my older male patients, it's something I say, listen, it's a known potential association. I can't promise you if you change what you do today, it's going to meaningfully decrease that risk. We don't have that sort of detailed data
Yeah.
yet. But it's certainly something where if you ever felt like I have palpitations suddenly when I exercise, or, another common one I hear is I was on the bike for 40 minutes and I noticed that my heart rate kind of spiked up. And then when I got off the bike, it was persistently elevated for a long time afterwards. And I just didn't quite feel right. To me, I feel like my role is to say, there may be an association with exercise over the course of your lifetime that puts you at risk for that. And so it's something I want you to be mindful of and watch out for and report back to us. Don't just dismiss it as, oh, I was dehydrated or I was a little bit overtrained that day. No, I want to hear about it. I
Yeah.
definitely do.
You said some of these folks are never going to come see a cardiologist, right? So
Yes.
right, they're not on our radar because they're the healthy cohort generally.
Yeah.
So that seems to be one of the challenges, but what are some of the challenges when you, or who are a researcher, are trying to study masters athletes?
Yeah, no, I totally agree that the first part of it is many of them are healthy and well, and they don't need to come see a cardiologist, and so
Right.
they don't necessarily have to or shouldn't. But that makes it hard to find them. In the medical record, you can't search them out by a diagnosis or by a medication use. So that's definitely a big problem for us. So we have to think of creative ways to trying to raise awareness within that population and reach out to them. And I'll say the other thing that's challenging for us is there's not necessarily a great definition of what an athlete is. We have used some definitions. There's an old Bethesda definition, but mostly that was developed for young athletes. And it's not perfect. And so, especially in science, when we're trying to put people into categories, for better or worse, defining an athlete is actually pretty challenging. It's kind of one of those things I think we would all say we know it when we see it, but if you really had to parse it down and split it out, it can actually be somewhat challenging to define that. Um, on the clinical side, I'll also say for those folks that are athletes that do come through the clinic, they still get valve disease, they still get AFib, they still get coronary disease. We don't often do a great job as clinicians in taking a good exercise history or even acknowledging that that's an important
Mhm.
thing that they do in their life. We underutilize exercise testing. We kind of take people at their word when they say, this is what I do and this is how trained I am. I take more of a trust but verify type of approach because I feel like there too, it's just not something that's kind of ingrained in us as clinicians to ask about. Just like we maybe don't ask great questions about someone's dietary habits, right? We get kind of caught up in other things and prioritizing other things. So I also know for the folks who are athletes who come through the clinic, they're getting through the clinic, they're being seen in various other spots. And that kind of title as an athlete or that flag as someone who really
Yeah.
values or prioritizes exercise and a high level of fitness, it doesn't appear in their chart. So it's hard to go back and
Yeah.
retrospectively evaluate.
And I think especially, I mean, another that just occurred to me while we were talking, the name of your clinic is sports cardiology, and person who has run for their entire life may not consider them a sports person. They think of that as
Yes.
team sports, playing
Yeah.
tennis or volleyball or soccer. So I can see how even self-identification might be challenging in recruiting those.
Oh, absolutely. I'll say it is definitely. So I just actually finished enrolling for a study looking at heart muscle stiffness and the effects of menopause in older masters athletes, but so particularly in females. And recruiting was really challenging. I would approach many females who I knew were running marathons or, competing in triathlons and say, "Hey, I've got a study looking at masters athletes." And they would come back and say, "Well, I'm not an
I'm not
athlete."
that.
And you say, "No, yes, you are. Yes, of course you are. Based on what you're doing and your level of the value and importance and prioritization that you put into your exercise training, absolutely you are." So even just on a personal one-to-one basis, sometimes that can be a really hard thing to try and navigate with patients or potential research subjects.
And I know because you and I have had prior conversations that when you talked about creative ways, I mean, you've gone to like running clubs and
Yeah,
talked to them and master swim clubs and things because you go to where they are because they're not coming to you.
exactly. Oh, that's been such a huge and a very important part of not only how we've kind of tried to build our clinical practice, but certainly also recruitment for research studies. You know, to be fair, many of those types of patients or potential subjects or individuals, they're highly motivated people, right? They really do actually want to participate in talking about their health and their fitness and their cardiorespiratory fitness. They really are engaged and interested in research, but they're just not necessarily hooked into the system. So yes, we've tried to be really creative in our sports cardiology group and making sure that we're connected with community groups, that we're connected with local races, that we've got good visibility with colleagues in sports medicine. If you're going in to get your knee injected before your next, 10K race, I would love for your sports medicine physician to just ask the question, hey, who's taking care of your heart? I'm taking care of the knee, but who's really looking after your heart? So we've tried to be very creative and very thoughtful in how we go out and engage that community. And to be honest, that's how we learn too, right? Because if I go to an event and give a talk on, let's say, coronary artery disease in older master athletes, it's so educational for me too to understand kind of what the narrative out there is or what the level of understanding out there is and try and bridge that gap. It's great for me also just to go out there and get the opportunity to interact with people outside of the clinic walls.
So as you look forward, either for clinical care or research, like what are you excited about? What's upcoming that we should be looking for?
Yeah. So right now, the kind of first thing on my mind that gets me excited now to think about, like I said, I've got this study. It was a fairly small scale study to look at both echocardiographic and MRI measures of heart muscle stiffness, so myocardial stiffness, elasticity, distensibility, and exercise capacity, and really the influence of menopause. There's some really interesting data on myocardial stiffness, let's say in a normally active or sedentary population. And there's a major inflection point in what happens with the myocardium around the time of menopause for females, which may be the type of thing that starts to explain some of the differentials between females and males in terms of HFpEF. Small, stiff ventricles are certainly a problem in that disease. So that data we're done actually acquiring at this point. So we're just trying to sort through it. I'm really looking forward to getting the chance to sink my teeth into that and start reporting some of that. And then I'll say on the other side, when we're just trying to think of other creative ways to make ourselves visible and try and engage with the athlete community, we've got a registry that's ongoing. It's been up and running for a couple of years now that anyone can respond to. We're looking for just masters athletes to kind of give us some information. It looks like an online survey that basically gets them hooked into a registry. For us, it's important just cross-sectional information about their exercise exposure, about their training habits, about medical issues that perhaps have come out, about how injury or time away from exercise might have impacted their lifetime of exercise. That survey is accessible anywhere, anytime to anybody. You don't have to be a Mayo Clinic patient to participate. There's a really easy to remember URL. So it's www.mayoclinic.org/athlete. That'll bring you right there. And that's a really important way for us. Again, if you think about how dispersed this population is, how diverse the population is, it's a great way for us to reach outside of the walls of the clinic and outside of our local regional area too. We've got respondents from all over the country and all over the world who can provide us with really important information.
Well, I'm hopeful that some of the listeners, maybe some of the cardiologists and clinicians out there who are masters athletes, might want to join your registry. So
Yes.
Thank you for giving that plug.
Yeah, no, absolutely. Thank you for the opportunity to spread the word. It's important, I think, cross-sectional data, but it also really opens the door for us to then say, hey, if in a future study we really want to dig into this particular patient population or cohort, it really gives us a great look at that population and an opportunity to go back to those individuals and say, hey, you were a participant in the registry. Would you be interested in pursuing these other studies, and really expand our ability to recruit for those in the future too?
Well, thank you so much, Dr. Larson, for this has been a fun conversation, and I've learned a lot. I don't think I quite qualify as a master's athlete, but I'm aspirational.
Yeah. Perfect. I think the moral of the story really with so much of this is so much of what we kind of would like to think is that we all should just move more. We should all exercise a little bit more, sit around a little bit less, and find ways to engage in your community where you can make that happen in a way that's, sustainable, that makes you feel good, that, engages your partner, your family members, whoever it may be, to get some social connection in there too. So really, I think that's the moral of the story, is that more movement, more exercise is almost always better. And we all could do a little bit more, or at least make it something we could do more with other people.
Well, thank you so much for that final inspirational message for me and for others.
No, thank you for the opportunity to be here. It was a pleasure, as always, to talk with you.
Yes. Well, this wraps up this week's episode of Interviews with the Experts, and I'd like to thank Dr. Larson for joining me today and discussing this important topic. We look forward to you joining us next week for another Interview with the Expert. Be well.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Rajiv Gulati, Chair of the Division of Interventional Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducation.mayo.edu and explore our live and online programs, our quick on-demand modules, and our CME accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.